Well, beginning this conversation this morning with us, is none other than Chike Ihwekwezu, who is a medical doctor and Director General of Nigeria Center for Disease Control, NCDC. He joins us virtually from Abuja. Thanks so much for joining us, Doctor, this morning, and it's good to see you again. Well, it's definitely not an enviable task you have on your hands. While we have the endemic ones, that's been our challenge over the years. There's COVID-19 right there. It must be an arduous task.
Yes, Ayo, it seems like a never-ending story. But I think one thing to note for Nigerians, we're at the beginning of the third wave of this new virus. We've gone through one and two as a country collectively. But as NCDC and with all our state government teams, we've also learned a lot over the last 18 months. So we're definitely not where we were in January, February, March, April last year. We're not even where we were in March, April this year because of what we've learned, how we've prepared. But one thing is for sure, we can't get out of this with the tools we have on the health and medical response side of things. We really need Nigerians to work with us. Nigerians have been so supportive over the last 18 months, made huge sacrifices. We wished this was over, but the reality is that it's not. This is a very strong foe, this virus. It has the ability to change, to become fitter. When we say new variants, that's exactly what is happening. The virus is adapting to humans, learning how to transmit more easily from one person to the other, adapting to our environment. So we have to keep adapting. We can't sit back and say, listen, we're tired. I wished we could, but the reality is we can't. So as the virus gains new capacity, new strength, new velocity, we have to gain more determination, more resilience, and more commitment to holding up the fight until we can get ahead of the curve. We've seen in some countries that they have been able to do this. They have a few more resources than we do. But collectively, with the spirit of Nigerians, I know we can mount yet another response to this very difficult foe that we're fighting, not just in Nigeria, but literally around the world.
Well, there's something you said, Doc, that I think I would like to, get a little more info on. When you say that, the federal, activities of the NCDC and the state EOCs have been able to learn a lot over time. I wonder what we have learned about the fact that people do not really use the MPIs, and that's, of course, why you are making that appeal. What have we learned about that one? Dr. Hikers, oh dear. I'm sure he will have him back in no time because it is interesting. There's so many other issues that he has raised, the NCDC has raised in other aspects of life, talking about cholera, dengue fever, Lassa fever, and so many others that we deal with every year. We have known that these things are always there. They're always in our faces. And what we do about them, now that's another thing altogether. Just recently, the NCDC released figures that indicate that about 816 deaths have been recorded from cholera alone within the past number of weeks, and thousands of cases, 31,000 or thereabout cases, have been recorded of that cholera alone. And we're paying so much attention to COVID-19, so one just wonders exactly how can we curtail these seemingly more deadly, concurrent, diseases that we have on our hands, as opposed to just paying attention to COVID-19, which some believe is not even looking as deadly as the ones that we have had over the years. I hope we'll be able to get Dr. Ihikwezu back now. Dr. Ihikwezu, are you with us now? Okay. We'll take a short break, maybe take one more report to see a thing or two that we may also still need to pay a little more attention to right up to now.
Officials of the African Center for Disease Control and Afreximbank hand over 177,600 doses of Johnson & Johnson COVID-19 vaccine to the federal government in Abuja. This shipment is the first tranche of the 29.8 million doses of Johnson & Johnson vaccine procured by the federal government through the African Vaccine Acquisition Trust. The WHO country representative describes the vaccine as a game changer for Nigeria as the country battles a third wave of the virus.
This pandemic still has a long way to run. Nigeria is already experiencing a third wave. The Johnson & Johnson Janssen vaccine we have today was listed for emergency use by WHO on the 12th of March. These vaccines are safe and effective and will be the game changer.
Officials of UNICEF and the African Center for Disease Control explained the rationale for choosing the Johnson & Johnson vaccine and encouraging citizens to get vaccinated.
The vaccine has a long shelf life and favorable storage condition. Last but not least, the vaccine is partly manufactured on the African continent, with finished activity taking place in South Africa. Our target is to deliver almost 50 million vaccines before the end of December.
This is the time to step up and get vaccinated, to take your responsibility. The vaccines are coming in and we must do our part.
Unlike the AstraZeneca vaccine, the Johnson & Johnson will only be deployed to hard-to-reach populations.
Because it is a one-dose effective vaccine, these doses will be focused on those who are in the hard-to-reach areas. That is to say, the riverine areas, desert communities, security compromised areas, and also the elderly.
Nigeria's COVID-19 infection rate has continued to spike in the last 3 weeks, averaging 500 new cases per day. But the government says the situation is not so bad as to warrant another lockdown yet.
Hassan Galadima, after battling to save the lives of 2 family members, finally lost the battle as the 2 young women died. He is at this graveyard to pay his last respect.
I lost my brother's wife and then my blood sister. My sister was discharged from the hospital. Then the ailment relapsed and then we had to rush her back to the hospital where she later died.
This is the graveyard in Zareku village, Miga local government area of Jigawa state, where the 8 people that died as a result of an outbreak of cholera were buried. You can easily tell the differences of the 8 graves from others because of their freshness. From the data we gathered in the primary healthcare in the community, about 268 cases have been recorded and more cases are arriving. Only 8 out of the 27 local government areas are yet to experience the outbreak of cholera, now ravaging Jigawa state. In Zareku village alone, 8 people, including children, died last Friday at a facility in the community in Miga local council area. The government is worried about the situation and is making effort to save lives, particularly of those in the hospital. So far, 5,000 cases have been recorded, out of which 100 have died.
The local government that has the highest number of these cases, as I mentioned during our last briefing, was Hadija, LG, and still remain the same. So far, so good. We are able to contain it. There is no new infection in the last 2 or 3 days. And we recorded from day 4 yesterday, we recorded there's over 100 people across the state.
Cholera is an infectious disease that causes severe watery diarrhea, which can lead to dehydration and most times death if not quickly treated. It is caused by eating food or water contaminated by a bacterium called Vibrio cholerae. And the safest way of preventing this from happening is by keeping high hygiene level. Sadiq Ilyasu, Channels Television News.
Definitely something to give attention to. We have Dr. Ihekwezu back, DG NCDC. We'll talk about that a little shortly. But before we lost that connection, you wanted to speak to us about the things that you have learned, especially, I mean, you and your team, when you talked about having learned a lot, especially in the light of the fact that people do not or seem not to be complying with the NPIs as much and as often as the authorities would expect.
Yeah, thanks, Ayo, and my apologies for that. Like I was saying, you know, we've learned a lot about the response in all ways, right? From laboratory detection to what infection prevention and control needs to happen in hospitals. We've learned about treatment, about oxygen, and all of that. But what I was ending with is that this is not something we can respond our ways out of. It really requires Nigerians to work with us like they have done so well for the last 18 months. And of course, you know, wearing a mask all the time is very difficult, right? Not congregating is very difficult. And so we've asked the leaders, so every congregation has a leader. So we've asked everyone to help us for one last push in this pandemic, right? We're beginning to get vaccines into the country. We've just announced our sister agency received 4 million doses of Moderna yesterday, another 177,000 doses of the J&J vaccine. We're expecting more of the AstraZeneca. So finally, we're getting in supplies of the tools that we need from a health perspective. But we cannot sustain this response just from the health response because we don't have enough. So we need everyone to join us for one, hopefully last push against this virus, to just hold back a little bit more, to ensure that people that they manage, that they're in control of, are able to enforce the measures that are so important to limit transmission.
But Doc, how do we convince people? How do you expect to convince people about COVID-19 when, I mean, just as you have noted, as at 1st August 2021, a total of 31,425 suspected cases of cholera, including 816 deaths, have been reported in 22 states of the nation. Oh dear. Well, hopefully we'll be able to get Dr. Ihekwezu back again. Seem to be having some tech issues with the connection from his end. We'll be back after now.
Well, indeed, while we wait to come back, while we wait for Dr. Ihekwezu to come back, I do think that the figures are a little chilling, Ayo. And when you look at the fact that this is happening in 22 states, and so far, the figures of people who have died from cholera, as Dr. Ihekwezu did point out in the briefing, which was done by the Ministry of Health yesterday at the Villa. So usually they have these periodic briefings from different agencies and parastatals of government, sometimes ministries as well. The ministers will brief State House correspondents, take questions from them on different sectors of their ministry. And I think yesterday was the turn of the Ministry of Health. We heard the Minister of Health to speak on the doctors' strike and why they will be adopting the no work, no pay rule. But when we got to listen to Dr. Ihekwezu, he was very concerned about the state of cholera in the country, which is a totally preventable disease. So it will be very interesting to know what collaboration is going on between the NCDC and also state governments, because when you look at the fact that cholera has now affected 22 states in total, and you look at some of these states, and you know, some of them you can understand because we understand what causes cholera. Some of them you can you can say, well, the chances are very high that this sort of state should be susceptible to it. For instance, Benue, that has Benue and Borno, two states that have huge populations of of internally displaced people who are living in camps, and sometimes sanitation might not be so great there. So, you know, there'll be huge questions as to, or there'll be some understanding as to what could have happened in those states. But when you see other states, for instance, the Federal Capital Territory, which has also been very affected by this cholera outbreak, you have to ask, how are we dropping the ball? You know, what measures are state governments and even federal authorities right here in the Federal Capital Territory putting in place to ensure that people have access to safe drinking water? What measures are we putting in place to ensure that we stop open defecation? You're traveling from the airport to the town, and along Airport Road, if you leave really early in the morning sometimes, the sights that you see, there are huge questions as to, you know, what have we done to ensure that we increase the number of public toilets that we have and that there is increased hygiene, which is supposed to be one of the gains that we have had from COVID-19. Ayo.
To ensure that we is with Dr. Ihekwezu, who, by the way, we have back. Thanks for joining us, Dr. Ihekwezu, and welcome back. Sincere apologies for this. So, you wanted to speak to us about some of these issues, especially around cholera. I mean, there are more fatalities, you know, from the cholera you will see within a much shorter time. It is a periodic ailment. You have told us that yourself, and one wonders, how come we have not been able to get ahead of it?
So, Ayo, yes, I hope this holds out. Cholera is really an endemic disease in Nigeria, and it is one fundamentally linked with water hygiene and sanitation. And what has happened in Nigeria over the past maybe 20 years is that we have taken our eyes off water as an important resource delivered by societies and their governments. And we have all relinquished that responsibility, even among the elite and the middle class, to individual responsibility. So we're all building our own boreholes. By doing that, we have taken away the political pressure on our leaders to focus on the provision of water as a fundamental need for the development of any society. And so when that happens, and when water reticulation systems fail, people resort to whatever local mechanisms they can to get water. Those that can afford it, dig boreholes. Those that can't, rely on rainwater and water from streams. And through that comes a waterborne disease, of which cholera is the most dangerous, right? So imagine you're fetching water from a stream. At some point in the stream, you have no idea what people have done upstream. And with open defecation happening, with the rains coming, what happens is people defecate around streams. The rain carries all that feces into the streams. Downstream, other people fetch this water, and then it starts circulating in the next community and in the next community. Cholera is a very tricky infectious disease. The reason is, it appears to be just, a little bit of diarrhea. And people don't realize how quickly individuals can deteriorate because of the rapid loss of fluids in especially younger people. So it leads to death very quickly. We start a response. We together with our partners at the state level, we mobilize oral rehydration fluids, drips, chlorination efforts. But all of that doesn't really affect the core of the problem. So my message has been, this is not a medical issue. This is really a societal issue with our government, local, state, and a little bit of federal, because the provision of water is not really a federal government responsibility at the level of our villages and cities. This is a state government responsibility, and we must refocus on this so that we can focus ourselves at NCDC at on the more difficult infectious disease, rather than every year we're going back to dealing with infections that most countries have dealt with and managed many years ago.
Well, perhaps there is a need to even decrypt the issues. For instance, on one of the documents that you sent, to us in the media, Figure 1 shows the map of Nigeria showing states with reported cholera cases, especially between week 1 and week 30 of 2021. What you will find, if you scroll, down that page, is that on page 3, for instance, we have a map, showing states reporting confirmed cases, states reporting suspected cases, and states reporting no case. This particular one, Dr. Ihekweazu. And one wonders, if you look at it, you see that most of the states affected are in the north. Is there any specific thing you've been able to find out as to why that is the case?
So, with every infectious disease, there's some geographical distribution. Right now, most of the COVID cases we find are in southern Nigeria. We recently had a monkeypox outbreak, mostly in the south. Cholera has predominated some of the northern states. And once circulation starts happening, once transmission starts happening, it spreads very quickly from state to state. So there have been states that have had regular outbreaks almost year on year. And we communicate with them directly. Some of the states in northern Nigeria, it's a factor and over-reliance on streams in certain parts of the country. So there are local circumstances in states that lead to the predominance of cholera in those states. But the issue that once transmission starts, then cholera then moves very quickly from individual to individual, because people then share not only the original source of water, which is where the infection would have come from, but they're now sharing this in communities, and it gets into the families and spreads from family to family. So the map really covers 22 out of our 36 plus 1 states in Nigeria have a cholera situation. Some are worse, some are a little bit better, but you can see that for any infection where it's so widespread in the country, really, this should be a national crisis at top of everyone's agenda on getting this right.
Well, Doc, when you're looking at this map again, a question that I ask, myself is, just as you said, this happens every year. We've always known it. So it would seem then that it is not a health problem, but maybe a political problem, if I can put it that way, because if government was able to provide the water access to people, and all of that, perhaps this wouldn't have occurred. What have you been able to find out as to why this hasn't been the case?
So I think underlying all of this, and this is a big factor in everything we do in infectious disease, is our population expansion in the last 20 years, right? Not only are we having challenges sustaining the delivery of basic amenities to the existing population of Nigeria, we are growing. We are growing at a population at a rate of 2.5 to 3% annually. Right? It means that we have to continue building up our social infrastructure to continue providing for more people. And there's nothing that people need more to survive than water. So once there's a strain on the supply of water, we have this impact that we have seen. So what we're asking our governments to do, I am part of government at the federal level, and we have state governors, we have local government chairmen, and the government at that level, is to refocus on the basics. We've gone a lot to building infrastructure, which is very important. But delivery of water is such an essential need. And if we do some analysis on our population expansion, and we can get that data easily from our population is growing, and we have to keep delivering basic amenities. And water is the most important of all the other needs to survive. And if we don't do that, the supplies will be strained. There will be pressure on the existing supplies. This will lead to people then looking for alternative supplies, which then leads to infections, leads to deaths. And we're in that vicious cycle of looking for a medical response to something that is essentially not a medical issue. So we will work together. This is not abdicating responsibility. We want to work together with the Ministry of Water Resources, Agriculture, but really work with all aspects of government to find a holistic response to this. If we don't, we will have a bigger cholera outbreak next year and the year after. So my essential point this morning is let's work together across board, across society. There's also an education component to it, educating people on what we need to do ourselves in schools, in homes, how important it is to boil water. That if you look at water, it looks clean. Doesn't mean that it's clean. We have to boil it. If we can't boil it, the chlorination, basic, simple chlorination, get some chlorine, drop a few drops in your water. It really helps against cholera, especially. So there are some things we can do in the household, some we can do in our community, educate our children in schools, try and provide sanitation facilities in our schools. You come to a school sometimes, even private schools, you see classrooms for thousands of children, and you see one bathroom and toilet facility, often without running water. So insist that before the Ministry of Education gives approval to a school, that they have the hygiene facilities that they need to support the number of students they have in the school. So we need to come together as a society, raise awareness about what we can do, not delegate everything to government, but government has a big responsibility, and we will continue working together with our different government agencies that have some responsibility in this area. That's what we're trying to do now, and that's what the minister has asked us to do, and pull together our different colleagues to really push this up the agenda in Nigeria over the next few years.
Well, it's not an easy job on the hands of government, Dr. Hukasu, because, I mean, just as you said, the population is growing. Are our resources growing in this, at the same level? That's another matter altogether. But is there a role for the people in all of this? Let's take that on when we return from this break, Doctor. Please stay with us.
As at 8th August 2021, a total of 1,534 cases, including 75 deaths, have been reported from 25 local governments across the state. Of the reported cases, 67% are aged 15 years and above, while 3 cases were reported to be under 1. Of all reported suspected cases, 53% were found to be male. 140 samples have been collected so far, within 43 rapid diagnostic test positive, 2 culture positive. Funtua local government had the record of highest number of cases with 384, followed by Sabwa, who recorded 232, Kafur 215, Cherenchi 135, Kankara 71, and Jibia with 69 cases. In terms of mortality, Funtua also leads with 18. Followed by Cherenchi, who recorded 14 deaths, Jibia 11, Kankara 5, Sabwa and Rimi having 4 each.
Thanks for staying with us. Dr. Hikwazu, you spoke recently at a conference and where you said every week NCDC detects cases of yellow fever, Lassa fever, measles, and other infectious diseases that are endemic in Nigeria. And they also said that there is a case of monkeypox discovered in the U.S. with travel history from Nigeria. Now, I'm wondering, Doc, how are we even going to take all these on board while COVID-19 is still right there in our faces. Cholera is killing, and we also know that all of these diseases that you have mentioned as well also have case fatalities sometimes. Doc, you might be muted. Could you kindly unmute?
Sorry about that. You're absolutely right about that. And that's where we have to give credit to this government. You know, when we started with NCDC a few years ago, it was a tiny agency, a tiny workforce, a negligible budget. But I think the federal government of Nigeria really recognized the importance infectious diseases would play in our country into the future. With 200 million people living in this small space, that doesn't get any bigger, right? The more people in a certain space, the easier it is for infections to jump from one person to the other. The socio-economic realities that are ours are the tropics, the heat, the densely populated nature of our cities makes it inevitable almost that this was almost a perfect environment for infectious diseases to thrive. So what do we do in the response? We have to build up our defenses. Our defenses at the state level, but also our defenses at the federal government level. How do we do that? We do that by building strong institutions. So we've spent the last few years building up NCDC from a workforce of 70 in 2016 to over 500 at the moment. We've built up a national reference lab that should be the pride of the country. We've trained individuals, young, smart Nigerians that are able to do the surveillance, to detect, respond to these infections. So what we have done is build up the intellectual capacity to prevent, detect, and respond. What we now need to do is to not go beyond that, educate Nigerians on what they can do, and push the leadership. Our governments have so many different priorities, rightly so. We're struggling with insecurity, we're struggling with infrastructure, education. So sometimes it's hard for these issues to get up the political agenda. So we keep pushing them. And those messages are being heard. Health security is now recognized not only as a health issue, but as a national security issue. And that's rightly so. We've seen the impact the COVID had on our economy last year. So we have to keep pushing on these things. Some of them we can manage, right? A number of the diseases you mentioned are vaccine preventable diseases. So we need to push our routine immunization rates up. Our sister agency, the National Primary Healthcare Development Agency, is working very hard on this every single day. But mothers, citizens need to know why it's important to take their children for vaccination. We're just talking about cholera, right? Government needs to provide water, but people can provide soaps in their houses, bar soap in bathroom facilities, learn to wash their hands. So there's a lot that we can do as a society. But Ayo, I think the most important message is that our environment is a perfect environment. As a society, we must give it the importance it deserves, the prioritization it needs, and we will find solutions. We want to be at the heart of the solutions now, no longer just recipients of therapies to solve our problem. So at NCDC, we're building a strong workforce to lead on this response, not only today, but into the future for Nigeria.
Well, so we had hoped that part of the benefits that would accrue, if any at all, from our experience with COVID-19 was the fact that our sanitation was going to improve a great deal and the consciousness of people towards sanitation was going to improve. Sadly, we've seen that on a yearly basis, cholera is one of the diseases that we have to deal with. And when you look at the states listed which are affected by this disease, there are huge questions questions to be asked. I mean, some states, as I was saying earlier with my colleague Ayo, that some states, you can understand that those states could be vulnerable. For instance, Borno and perhaps Benue, where you have huge numbers of internally displaced people living together in camps. However, some other states, you have to ask, especially a place like the Federal Capital Territory affected by a disease, a preventable disease such as cholera. You have to ask huge questions as to if any benefits whatsoever have accrued to us from our awareness about sanitization and the purity of water and how we need to keep our environment and our hands clean. Have we really gained any benefits from this? Have we learned any lessons from the outbreak of COVID?
I think we have. I feel your frustration on the lack of on the speed of progress, right? Just yesterday, I was speaking to the Honorable Minister for the Federal Capital Territory. I could feel his pain and his own frustration at the number of cholera cases and deaths occurring at the FCT and his commitment to doing something about this. The FCT, people often think about it as just central business districts, Maitama, Socorro, and the places around the capital. But, FCT is far bigger than that. And within this capital territory, there are many portions of it where the circumstances are a lot worse than we find in the middle of the city. So what he's doing is trying to address this. In fact, his central message is that we must not be completely taken by COVID, and we must make sure that we respond to diseases that affect everyone in society. And he has assured me of his prioritization of the response to cholera by providing the facilities needed. However, Maupe, this is a marathon, right? It's not a sprint. So what happens almost every year is that we have this outbreak, is on TV shows, we're all interested, and then we all forget because other problems come in the path of the investments that need to be made. So what we're trying to do now, and this has been the mandate that Minister gave us, to make sure that we really call together the multiplicity of stakeholders involved in delivering what is needed to prevent water transmittable diseases, which cholera is the most important. But let's not give up. I know it's been a hard journey. It's hard to see citizens of Nigeria die from a disease. To be honest, many countries have not seen for decades, literally. Cholera, it should not be a challenge that we're faced with in a modern society in 2021. We have to get above this. And I think this has woken us up in Nigeria to that fact. And collectively, we need to find the political will, the energy as a population, the media as a critical stakeholder, a role player in this, to push and say, listen, it is completely unacceptable for 816 people confirmed this year to have died from cholera, a disease that is almost non-existent in many other countries in the world.
And so you have to ask, I mean, when it comes to the political will, I do know that a few years ago, we launched a program, a campaign against open defecation. We saw the billboards here in the Federal Capital Territory. Yes, I do acknowledge that indeed a lot of the health challenges we face, we mustn't address them like sprints. We must address them as a marathon. The question is, if we have seen the sustained energy and if we know the people responsible for the program, so is it just a general launch and then after that, we all go home? We all know that open defecation is still a thing right here in the Federal Capital Territory. And it's not even happening in the suburbs. Yes, it might be happening in the suburbs, but we see it happening right, approaching the heart of the city. There are huge questions as to whether we've really put our money where our mouth is. Dr. Ihekwazu,
yes,
can you hear me?
Address, right? One, open. Yeah, yes, I can. Are we back on?
Fantastic. We lost you for a bit. Please go ahead.
Okay. Yeah. So So with open defecation, this is really a multi-pronged response. One key point I'd like to make is we don't actually need to wait till we have the perfect water and sanitation response that is, an ideal situation. We can build safe pit toilets in certain environments that is not ideal, but is better than just open defecation in the field. So there's a lot of education we need to deliver, so that even if you say, listen, I have an industry manufacturing complex somewhere, it's not easy to get water supplied to that complex. Boreholes are difficult. What is the alternative? There are alternatives. And so we have to look at these alternatives and provide them. And secondly, very often, employers too are a problem. People build up companies, have offices, but don't really think about where their workers will, ease themselves. So there's an education component to this. Not everything should be left to government to do. Companies can take this up as their civic social responsibility and do some of these things for our societies. But really, there's no magic bullet out of this. This is not even an issue like COVID, where we say, okay, listen, we're going to get vaccines and vaccines will solve this problem. There wouldn't be a vaccination solution to this. So we will get back to the basics. We will have to get back to the basics of water, hygiene, soap, toilets, all these problems that societies have to solve as they develop. This is really what we have to focus on as a society. And, we're going into an election cycle in a year and a bit, right? We have to push. Nigerians need to know and ask the hard questions of the leaders that will come to them seeking their votes, right? And to push these agendas up. If they do so, we will find a government, and this government has invested a lot, opened up that campaign and done its bit. But as we elect the new set of leaders, we will sustain the momentum built over the last few years, so we can take this into the future and build on the progress we have made already and make sure that every year we're doing a little bit more to prevent the next outbreak. And so really the central point of this is there's no magic bullet. We have to invest on all parts of the response, on education, on facilities, on water, hygiene, sanitation, our schools, our churches, sustaining hand washing, and collectively with all the agencies, we will make progress. But this will only happen if citizens insist and keep this on the political agenda way beyond the outbreak that we're facing at the moment.
Well, the huge question for me is whether we're recording progress. Because we know that year in, year out, there are some diseases that are seasonal. Lassa fever, we know it will come in the dry season. Well, we hope it doesn't come this dry season, or we don't see the rate of fatalities that we have seen in the past. For cholera this year, it seems that we have seen a remarkable rate of fatalities than we would normally record. Can you confirm this? And if indeed it is true, is there anything that you would say is particularly responsible for this?
So yeah, cholera, at least in the Nigerian context, we see kind of what we call high seasons in a 3-4 year cycle. So in 2017-18, we had also a very bad year around a similar axis, started in Bauchi, went to Kano, so kind of that northwest axis. 3 years ago, 2017-18. And 3-4 years later, we're seeing a similar cycle happening. So we kind of know the cycles. What happens is, there's some level of passive immunity that builds up in those populations over a few years. And that's why when you do a cholera vaccination campaign, it's kind of the vaccines are only effective for about a 2-3 year cycle. So we understand the immunity cycle of cholera lasts for about 2-3 years. And then when immunity wanes and the reintroduction of this infection, you see another outbreak. 4 years ago, we had a big vaccination response in Borno State, focusing a lot on the IDP camps, which was very effective. This year, again, we've done a campaign, a limited campaign, vaccines and scarves for cholera, and effective only for a few years. So it's not a huge part of our health response, but we did use it to respond in Bauchi, specifically because of the intensity of transmission there at a point in time. But yes, it does happen in 3-4 year cycles. So, and that's a bit of a challenge because cholera, with this outbreak this year, the likelihood is that next year we won't have a big year. So, you know, begin to forget. So we will keep that is now going into the response that we have seen across government, state, federal, parastatals is sustained even when there are slower years of transmission of this virus.
Well, that's definitely something to keep in mind, because one might think that, oh, the following year when we don't see such an outbreak, oh, perhaps we're making progress. But if we keep in mind that this is something that could happen every 3 years, then maybe we will be able to make real progress in that regard. I wanted to quickly ask you about this Marburg virus, which is of concern to the WHO and has been discovered in Guinea. Is it something that is of great concern to the NCDC, considering that it has Ebola-like properties from what we hear?
Yes, Marburg, sorry, and I just called cholera as a virus. It's actually a bacteria. To Marburg, absolutely. So we are continuously on the watch out for Marburg and Ebola. Marburg and Ebola have very similar characteristics. And the very interesting and intriguing and worrying thing about Marburg in Guinea is that it's the first time this virus is being found in Guinea and in that extreme west of West Africa. So Ebola and Marburg are very intriguing that we haven't quite fully understood where it emerges from. So spontaneously you find a cluster of often deaths, you start looking for a cause, and it ends up to be this virus. So we're very aware, firstly, it tells us that we have to always be on our guard here. So we set up a risk analysis team yesterday, actually, evaluated the risk for Nigeria. It's low at the moment, but what we did is make sure that we have the facilities, the commodities to detect this if there were to be a suspect case. And of course, we're now watching out for travel. We're working with our colleagues in Port Health Services, looking at the travel history of individuals that are traveling. But the most important response to something like this is to control it at source. So we're also in communication with our colleagues in the West Africa Health Organization and the Africa Center for Disease Control to provide and offer whatever support we can to the colleagues on site, but to make sure that as a collective on the continent, beyond Nigeria, that we always are aware of risks and able to manage and mitigate this at the point where that risk is emerging from. And in this case, it's in Guinea, in West Africa.
Dr. Hekwazu, one other thing that concerns me, back to the endemic issues that you began with earlier, Lassa fever, yellow fever, measles, and other infectious diseases that are endemic in Nigeria. Is there a role for the people in these various communities? We are a communal people. We always like to be together and all of that. And here we are. The more we are together, it would seem, the more likely we infect each other. Is there a role for the people in all of this melee?
Yeah. So this is a very interesting question. If you look at the history of Western Europe, for instance, and the decline of infectious diseases in Western Europe, this was not really associated with any medical intervention. This happened passively as the standards of living improved over time, and people lived in smaller setups, the infrastructure improved, housing improved, water improved, sanitation improved, and almost a side effect of that was a reduction of the transmission of infectious disease. Now, we have a unique way of life in Nigeria, which we don't want to lose, largely. You're absolutely right. We do a lot together. We eat together. We celebrate together. And that comes with some risks. So as a society, we need to learn how to mitigate those risks. So whatever we are together, right? And if we're going to eat together, for instance, from the same plate of food, that there will always be the maybe oldest person in that group that says, listen, okay, now let's all go and wash our hands together as well, if that's what it will take, right? And we hold ourselves, we are much more educated about the risk factors around transmission. And I've said this on this show many times, not only at home, in our hospitals, schools, we need to learn to do the simple things while not losing those such beautiful aspects of our culture that brings us together. But right now, if it's our culture to have a big ceremony as a wedding or as a whatever ceremony that we're planning that pulls together thousands of people into a single enclosed space, the fact is that within the context of COVID, that will expose you and your guests to significant risks. So you have to mitigate those risks by limiting the number of people you're inviting, insisting on mask wearing, insist on a certain level of distancing, at least as we fight this biggest infectious disease threat of our lifetime. So there's a conflict between our culture at the moment and the threats that we face. But I think if there's a decision to be made between life and culture, I suspect that the decision should be obvious to most of us.
Well, there was something also, to take away from what you have said is that if infrastructure improves, the side effect, or rather the side benefit would be that some of these situations that we have on our hands would also come down. It would seem then that it's more, you said it earlier, it's less of a health or medical intervention that is required as opposed to political or policy or infrastructure. In conversations with the states, is there any possibility of a timeline being come up with anytime soon, so as to how often will be, or how frequently, how soon we'll have some of these infrastructure so that these risks might reduce? Dr. Hekwazu, okay, I think
yeah. So you asked about timelines.
Yes, go ahead.
Yeah, you asked about timelines. I think it's very difficult to offer development timelines for countries, states. It's very difficult and also a little bit beyond the scope of my responsibility. We contribute to that in different ways. Both building, even for infectious diseases, requires a certain level of investment in infrastructure, rightly so. We also provide advice to other aspects of government in terms of what they need to do to develop their infrastructure. And as we continue developing as a society, the impact will be similar to what has happened in the West, and which is why this really is a collective effort and needs to stay not only on top of the health agenda, but on top of the political agenda, not just for the next couple of years, for the next 10, 20 years.
Well, it would seem then that all the ministries, departments, and agencies in the health industry in Nigeria are collaborating. But then there is usually that question of funding. Is there a funding problem to taking on some of these issues from where you, from your perspective?
For the work that we do specifically, I must say we've been fairly well funded to respond to the COVID outbreak in the last 18 months. What we're now trying to do is really work out what level of funding is required for health security as part of a collective investment in the health sector moving forward. And I think there's an increasing recognition at the federal and state level that this is important. If we want to be able to detect these new viruses, to carry out the surveillance that we need to carry out, prevent spread through the focus on infection prevention and control, requires a certain level of investment, which costs money. But the other thing, too, is just investment in the health sector altogether. We budget plus minus 5% of our total budgetary allocations towards health at the federal level. That varies a lot at the state level. Anything from some states have gone over 10%, closer to 15%. Many are still even below 5%. So that's the first thing. Secondly is the effectiveness of the funds and the inclusion of other players, such as the private sector in the delivery of healthcare services. So we've seen a rapid expansion of high-end private sector health facilities over the last few years. We've also seen the National Health Insurance Scheme really pushing hard to expand the number of people that benefit from health insurance and therefore put in more resources into the sector. So in conclusion, the point I'm making is that it's not just to health, it is also
Oh dear. Well, I was just hoping that I'll be able to ask. Okay, well, you're back. My apologies for that. I just want to very, very quickly ask you. You must be concerned about the fact that the workforce in the health industry is also greatly depleted with the strike of the NERD. How is that affecting your work or our interventions in any way that you know?
So far, the impact has been minimal, but it will get worse as the strike persists, right? And I think there are very deep issues that are worth the discussions happening and have to be resolved. Many of these are long-standing issues and they need resolution. And I'm very glad that the Ministry of Health, both ministers, are so engaged in this problem, our National Assembly, to resolve it. But there's no doubt about it. You know, the level of vulnerability we have as a country because of the strike action will increase exponentially. Is that while the issues at stake for resident doctors are very important, we have an existential problem as a society, as a humanity, and that maybe the might consider that this point in time, and we can really resolve these issues outside of this period and hold on till we get ahead of.
Well, Dr. Ihekweazu, we can only wish you well in all of the things that you do for us in the country. Dr. Chikwe Ihekweazu is Director General, Nigeria Center for Disease Control and CDC. Thank you so much for your time and your perspectives this morning. Sunrise Daily continues in a moment after these messages.
Well, the issues are many, but we have very articulate minds to intervene on the matter. Dr. Osaho Inabulele is past president, Nigerian Medical Association, chief consultant, family physician, president of the Commonwealth Medical Association, and a member of the executive committee of the World Medical Association. You're welcome to the program, sir.
Thank you very much, Mark.
We also have with us Dr. Ike Odo, who is the president, Association of General and Private Medical Practitioners of Nigeria. You're welcome to the program, sir.
Thank you, Mokwe. Good morning, Nigerians.
Well, let's quickly take your intervention, because this strike of the National Association of Resident Doctors has gone on for about 2 weeks now. What's your reading of the steps at mediation and reaching a resolution? Are you satisfied? Do you think one party is guilty over another? Let's quickly have your take, sir.
Well, thank you very much. I think a lot more needs to be done to make sure that these issues are quickly resolved, and a lot more from the government side. To make sure that the perennial issues, what has become almost like perennial issues, are quickly resolved. So they must, continually engage rather than issue threats and some declarative statements that do not inure, to the progress of the medical sector. So they must get back to the negotiation table and engage the issues in a way that will bring progress in the health sector rather than being adversarial, in their own engagement with the resident doctors. The issues, the demands are very legitimate. They are germane. They've been on the table. And of course, there are even laws that even obligate even the government functionaries to implement certain provisions, for instance, the Medical Residency Training Act of 2017. So nobody should, be bellicose about this. We must engage the issues from a patriotic standpoint. So I want to advise that rather than institute some measures, which they claim are punitive, for instance, the no work, no pay policy, which I consider as very bourgeois, a very bourgeois prescription, because there is no pay, no work, and yet you have no work, no pay. So those such bourgeois prescriptions should be downplayed and in a very patriotic manner, engage the issues and resolve it as much as you can.
Okay, I'm just wondering why you think that the NMA has not been as declarative as it ought to be concerning the strike.
Well, I'm not the president of the Nigerian Medical Association. I'm sure he's the spokesman for the NMA, and I'm sure they will speak at the appropriate time. But I'm aware that the NMA has been involved in some of the meetings that were called by, the National Assembly, particularly the Committee on Health Services, led by Honorable Tanko Sununu, who has done, who has exercised his roles in a very commendable fashion. So I'm sure the NMA president at the appropriate time will make a very profound statement.
Let me quickly have your take, sir, on the issue of the strike. You head the Private Medical Practitioners Association of General and Private Medical Practitioners. There are those who believe that, that sector is going to be the beneficiary of this particular strike action. Is that the case?
That cannot be the case. We can't be seen to be beneficiaries when our colleagues are endangered. The frustration of our colleagues should not be our own benefit. We are one, public or private. The question of the NAT strike is a major concern to everybody. And for a country, a developing nation like Nigeria, we need to do a lot more than we are doing. We must wake ourselves up from the self-imposed slumber of social decadence. We can afford to do more than we are doing for our country, for our doctors in particular. The average NAD member, the average doctor in this country, these are the reasons, these are the factors. How can doctors be in pain? How can they be like warriors in the trenches with their own government, their own people, a people they have vowed and unpledged to serve, to labor for, to put their lives on the line? How can we be from one problem, one complication, one battle to another, like my dear colleague said, my president said, perennial, a recurrent decimal? It questions our consistency, it questions our commitment, it questions our will to collectively address our own problems and provide solutions. We don't have to refer to anybody. We are a nation. We should look inwards and prescribe for ourselves what we think is best suited for us. That is what I think. The NAD problem should be addressed. The table is the best battlefront. Let's talk. Let's agree. But after agreement, implement the terms of the understanding.
Well, while we're waiting for that to happen, there have been huge questions on every part. First and foremost, what impact this is going to have on our medical sector. There's definitely concern on the current state of our medical sector, and it is reflected in almost every area. I mean, if you look at the current challenges that we're facing, cholera has claimed the lives of over 800 people so far, even though we've been told that, yes, it's not particularly a medical, it's not only a medical challenge, and primarily the fact that people even have cholera raises its own questions. But then cholera is a treatable disease, isn't it? So there'll be questions as to how this many people have lost their lives to something that we could have caught on time and treated. I do not know if you have your thoughts on that.
Well, everything borders on the issue of the commitment of the government to health system reforms and ensuring that the necessary capacities and environments are created to stave off issues like this, which, of course, is very blackmailing to a country like Nigeria, that to date, we still have issues of cholera, confronting our people. And if you like, the ordinary people, who, of course, are living in the fringes and even sometimes in cities. So it boils down to the issue of how committed we are to health system development in our country, the issue of health system resilience and all of that. And a clear example is the fact that even as we are speaking now, to show the level of disconnect by the leadership, in terms of the health system development issues, the president, is way abroad. Procuring healthcare services abroad, along with some other officers of government. So clearly, these are issues that border on simple strategic reforms, including at the level of the communities, for instance. The issue of health education, the issue of health advocacy, the issue of emplacing preventive measures and modalities on ground, and ensuring that they are there on a sustainable basis. Not this off and on thing, today is cholera, tomorrow is polio and all of that. So I think it borders on the issue of reforms, the issue of commitment to health system development, the issue of investment in the primary health care system, for instance, which of course should attend to some basic issues within the communities and all of that. The issue of ensuring that there is some level of sustained funding.
We know what to do, because there's been a lot of conversation on this.
Absolutely.
Right? We've also talked about universal basic primary health care, or something.
Universal health coverage.
Exactly. Now, what is the gap? Why is it so difficult to will I say, see significant progress in implementation? Because for a number of people, that's where the gap is. It's not like as if we haven't had enough conferences talking about the general decadence in the health sector and what needs to be done. Why is that gap still as wide as it is?
Yeah, like I said, one of the key drivers of health system development in terms of, the agreed parameters is the issue of leadership and governance and the issue of commitment to healthcare development. That is primary. So when you do not have that consistent engagement by the leadership, and in fact, if they do not understand the nexus between health and development, then it becomes a major problem. And that explains a whole lot of the gaps that you see. That yes, the solutions are there, but who is implementing? Who is tracking? Who is monitoring the progress of the health sector? 2014, I was part of those who sat in Aso Villa, and we made a declarative statement on universal health coverage, of how Nigeria should attain, universal health coverage. But after that, it became a piece of paper in the shelves of government functionaries. So nobody is tracking, nobody is monitoring, nobody is sustaining the investment in the health sector. We will wait for COVID and others to know that, healthcare system is in a very, lugubrious state. So the issue of leadership and governance is key. There are other ingredients. The issue of healthcare financing. The issue of ensuring that we have even community engagement. Because again, if the citizens are not involved in your health system development, you're just going to be wasting time. So how involved are citizens? What is the state of the private sector, which is a critical, sector in health system development? Because when we talk about health, we're talking about the private and public. So the overemphasis on public to the neglect of the private is also not helping issues. So there are a concatenation of factors which the leadership needs to engage on a continuous basis. And that is why reform is a sustained dynamic process towards ensuring continuous progress and quality in our health systems.
I have a confession to make. I usually love to read columns. And today, in the back page of Leadership, you have this conversation with Azu, and he's writing about an encounter with a doctor. It's your life. It's a pretty interesting read. And I think that for a number of people, if you read the stories here, it summarizes oftentimes the sort of encounters that we have with doctors. A lot of people have abandoned government hospitals. It's only when people are pressed that they go to government hospitals. You know, those who can afford it oftentimes will go to the private hospitals. But then there are questions of standards. You know, who is looking at what is happening? Who is looking at even the little that we have? How we're ensuring that the best service is provided when and how it is needed. Who is ensuring that, you know, whatever happens in that particular sector, somebody is held responsible for it. As a doctor, you cannot do this. As a doctor, you cannot do that. Or as a medical practitioner, or as a, you know, someone, if you're a nurse or whoever it is you are in the sector, you know, there's certain things that you cannot do. And if that happens, you are held responsible. Is there any conversation around that, especially in the private healthcare sector, Dr. Odo?
Yes. My president has said it. We have one health system. No Nigerian suffers from a private malaria and none suffer from a public malaria. We need to have a holistic approach to emphasizing the development in the healthcare delivery system. As a matter of fact, the private medical sector of Nigeria is the largest provider of healthcare. It is very obvious. 7 out of 10 Nigerians who need medical care out there end up with the private sector. The question then is, why is the same private sector almost completely outside the radar, outside the coverage, outside the purview of government? Government does not seem to know that they are there because we have been there. Yesterday, we marked our 100 years as an association, for example, showing that for 100 years we've been there silently but very consistently supporting the healthcare delivery system of the country and anywhere in the world.
Yes. What
the
do you
private sector.
What precisely do you want government to do? Because some people will say that government hasn't quite paid enough attention to the one it is responsible for. I mean, directly responsible for. Yes. What exactly is the private sector looking for?
The private sector believes that it's been left to its own to struggle. Whatever your capacity as an individual or group is what you end up with. And yet, anywhere in the world, government is the driver. Government is the patron. Government is the authority. They come in, provide the enabling environment, provide a supportive atmosphere for the sector to thrive. Go to Dubai, go to India. What is the magic? There are no magicians in India. The Indian doctors simply have an understanding with the private sector and government. Government said, what can we do for you? They gave them health banks. The taxes for doctors or for hospitals are not the same. They are obviously subsidized. If you have to make import for your consumables, for medication, why all the taxes? Why will I have to go to a bank as a hospital provider, a care provider, hospital owner in the private sector, and the same interest rate that oil companies are giving is what you get? And the hospital is not a business. We are social providers. Government needs to come in, support this system, give us that opportunity that we need. Infrastructure, light, power is a big issue. Over 40% of your earnings in the private sector goes into power. It has become part of the basic requirement for your facility to be accredited, for example. You don't come to a hospital to accredit, you must show at least 2 generators. Minimum standard now. How many Nigerians can afford it in this era? Especially with the somersaulting and the tumbling economic indices in the country.
Why is it so difficult for entrepreneurs in that sector to partner? For a number of people, it would seem that, you know, when they do go into private practice, you know, one individual oftentimes tries to go it alone. Why haven't we seen more partnerships in that sector, considering the challenges?
We are seeing partnerships, and partnerships are beginning to grow. It's understandable. It's about human nature. It's about the individualization of concepts, the difficulties in the compatibility of men. Some have succeeded, Some have failed, and it is the same anywhere in the world. But we can see group practice growing by the day in Nigeria. And as a matter of fact, they are the real people, the real centers that are keeping Nigeria today. The private sector, both at the primary, secondary, and tertiary levels, are the ones giving Nigeria the identity and the hope that we have in the private sector.
The original question was about standards, you know, about what happens when standards are not kept. About the falling standards of medical services being provided when medical services do exist.
No, we have clearly defined standards. The MDCN, the Medical and Dental Council of Nigeria, stands there as the regulator. Standards are kept at the state levels. The Ministry of Health has its monitoring teams, and standards are well defined, and they are kept. And of course, the medical profession is about ethics. We are a people of ethics, a people of protocols, a people of values. And those standards are defined, but what we want to ensure is that they are monitored, they are evaluated, and they are sustained to be sure that none falls below those standards. And it's been done. Just last week, the MDCN had its open trial of doctors who probably have been seen or cited to have fallen below the standard, to show you that monitoring is a key component of what we do, and the MDCN is not sleeping over it. As an association, we sing it like a song. You cannot afford to play with standard because we're not carpenters. A carpenter can lose his table and replace it the next day. Ours is the most demanding of all professions. We deal with life, and none can be replaced.
Let me quickly ask you how brain drain is affecting the manpower that you have in that sector. Is it a big issue for you?
Mokwe, and I want to use this opportunity to tell Nigerians that let nobody deceive us. If there was any time that something should be done about brain drain, this is the time. Let me just share my own experience. In my small facility, last year alone, I lost 5 radiographers to the UK. This year, I have lost 7 doctors to the UK. 2 radiographers have gone, and many have tendered their resignation. As I speak, my gynecologist has his family out already. He has planned to leave. He's on annual leave now, but had planned to be given 2 months work, leave without pay to enable him settle. They are leaving. Everybody wants to leave. It's as bad as the average Nigerian doctor or nurse or pharmacist closing his eyes and jumping into the next available plane. He doesn't care where it lands anywhere, as long as it's outside Nigeria. It's as serious as that. In one of my interviews, I made it clear that the next cancer that might exterminate the entire health sector is the brain drain.
Let me quickly come to you, Dr. Nabulele. I do not know, how you think that Nigeria can address this issue, because you heard the Minister of Health there saying how much the Nigerian government also spends in training its doctors. The question is whether we're spending as much to retain them, to make sure that they stay after we have spend so much in trying to get them trained.
Well, thank you very much. But first, let me go back to the issue of service delivery and the issue of quality. The reality is that there are providers who are doing their part, like the private sector and even the doctors and other health professionals in the health sector. But the reality is that Nigerian landscape is riddled with what I call charlatanism, quackery at its highest. And that informs the need to continually engage the issue of quality and standards. Unfortunately, the Prescription in National Health Act, which obligates the officers of government in the Ministry of Health to prescribe certain standards and even issue a new directive on the certificate of standards, is yet to be implemented. The issue of clinical governance and establishing clinical governance units in the various health institutional sectors is not being done. So, yes, others are doing the part they ought to play, the doctors, other health workers through their regulatory bodies. But the reality is that in Nigerian healthcare, one of the things really impinging on the development of the Nigerian health landscape is the issue of quackery, charlatanism. Now, to the issue of brain drain, it's not enough to say you are investing in training. Beyond training, how are you investing in the retention mechanisms? Because issue of health workforce is about production, retention, and of course, motivation. So the issue of production is there. We're not producing enough. So how are we investing in the production capacity, health production capacity, in terms of the institutional frameworks for producing the health personnel? Today, we need in the medical sector over 250,000 doctors to meet with the ideal ratio, 1 doctor to 600 patients of population, prescribed by the World Body. Nigeria today is revolving around 1 doctor to 4,000 population. So that cannot impact on useful health outcomes. That cannot drive useful health outcomes. So how are we producing? How are we, even those that are produced, how are we training and retraining them? How are we retaining them? I mean, look at what is happening now with the whole issue that has prompted the NAD strike action. I mean, people even want to come into the system. The recruitment policy is so defective. People can't even employ because you have to apply for waivers. I mean, such bureaucratic retapism and administrative shenanigans is not helping the development of medical manpower or health manpower in our country. So what motivational mechanisms do we have on ground? As I speak to you now, the environment is so defective, largely. The working conditions are very pitiable. And, of course, buoyed by the issue of insecurity, which affects all Nigerians. Nobody wants to spend time, the rigors, going through a very high-skilled profession like medicine, for instance, only to come tomorrow you are kidnapped and all your little savings have been, of course, released to kidnappers. I mean, once you are freed from the stranglehold of the kidnappers, the next thing you think of is how to survive. And there are people who have alluring, attractive mechanisms coming even to Nigeria to attract those healthcare workers. I mean, so others, the push and pull factors need to be engaged by governments. There are factors that are pushing our doctors, including the working conditions, the poor, uncompetitive wages, the insecurity issues, all right? And, of course, the attractive pull factors from other places. Even in the midst of COVID, you saw the UK government emplacing very attractive policies and programs for healthcare workers all over the world in the face of Brexit. And who will not get attracted to that? So for those of us who are even straining ourselves to remain in our country, I think we should be appreciated. But that is not even being done. Because rather than patronizing Nigerian professionals, health professionals, our government is patronizing those abroad. So it further tells me that I am not even valued in my own country. So perhaps the best place to be valued is to go abroad, where I will have the opportunity to treat my president, to attend to my president, because that also gives you some level of self-esteem and professional esteem. That, you are here treating your president. So if I cannot treat my president in my own country, would I want to go outside to treat my own president? So the issue of recognition of the sense of worth, the sense of value, and the merit of the healthcare professionals in our country also needs to be addressed. So there are a lot of factors in this. But my worry is that it looks like a vicious circle. Because I tell you, I presented a paper on this at the Commonwealth level as far back as 2004, 2005. So the issues are not new. But what is missing is the commitment towards the sincere resolution of these problems.
It's a fine place to leave it. I think you have summarized it very nicely, and I hope that it's able to kickstart even further conversations and, also some introspection on our part. Gentlemen, thank you so much for your contributions this morning on Sunrise Daily. Dr. Osahon Enabulele is the past president, Nigerian Medical Association, chief consultant family physician, president, Commonwealth Medical Association, member executive committee of World Medical Association, and Dr. Ike Odo is the president, Association of General and Private Medical Practitioners of Nigeria. Once again, gentlemen, thank you for coming on our program this morning.
Thank you, Marquette. Thank you, Nigerians. Thank you, Nigerians. And we pray for the best.
Well, let's quickly see if we can take a few mails from you. Festus Akimboyewa, you talk about containing COVID-19 in Nigeria. You say until we take tests, trace and isolate seriously in Nigeria, and federal government, states, public and local partners such as businesses, schools, hospitals, prisons, etc. work together, it will be difficult to contain COVID-19 in our dear country. Government must be bold to take enforcement action against the pastors and imams who are pushing conspiracy theories about COVID-19 in Nigeria.
cholera outbreak. The outbreak of the cholera in those states is a pointer to say the governors are not doing their jobs. When you check these areas where we have the outbreak, you will see that there is no government presence. And it's as a result of we leaving out our closest governments to focus on the central. We've predominantly vented all our anger on the FG. Meanwhile, the issue of clean environment and potable water and some basic amenities are the functions of state governments. Let the governors perform their duty.
Well, Henry, we also see your mail. The title is a very good summary of what it is. We do not have the time, but I'm just going to take the title. You say, cholera, there should be no excuse. And I think that basically summarizes the stance of us all to this particular disease. There should be no excuse indeed. We have to thank you all for watching the program this morning. It's been a pretty interesting one. We hope that you have a great weekend and that you stay safe. Thank you for watching. I'm Maokwe Ogun Yusuf.
And I'm Ayo Makinde. Stay with us on Channels. More to come.